Hello, everybody. My name is Cassandra Larson, and I will be discussing intermittent explosive disorder. Intermittent explosive disorder, also known as F63.81, is found in the DSM located with that diagnostic code. Intermittent explosive disorder includes frequent outbursts that can be attributed to various things, such as physical violence toward property, animals, or people, or verbal aggressions, such as tantrums, disagreements, or fights, that happen twice a week on average for 3 months. The second attribute is during a 12-month period, 3 behavioral outbursts that result in property damage, physical assault against people or animals, and the diagnostic features include impulsive or anger-based aggressive outbursts that typically last around 30 minutes in response to a minor action. The diagnostic criteria falls into different categories, and the first category is criteria A. There are 2 criteria under criterion A, one with verbal aggression, temper tantrums, tirades, verbal arguments, or fights, resulting in physical aggression toward property, animals, or others occurring twice weekly for a period of 3 months, as I mentioned previously. Criteria A1 defines frequent outbursts, and the other criteria involve 3 behavioral outbursts that do result in a physical injury against others within a 12-month period. Criterion A2 defines infrequent outbursts, for example, 3 outbursts in a 1 year or 12-month period. For criteria B, there is a glaring disparity between the level of aggression displayed during the frequent outbursts caused by any action. Criteria C includes a recurrent aggressive outburst, however, there is no pre-calculated motive or intention. For criteria D, there's a frequent violent outbursts that have negative impact on interpersonal or professional performance, produce significant distress in the person, or may have financial or even legal consequences. Criteria E requires that the individual is at least 6 years old, and for criteria F, provides information based on the reoccurring aggressive outbursts and how they are not better explained by other mental disorders. For the course and prevalence, intermittent explosive disorder is frequent problematic outbursts of impulsive aggressive conduct that can seriously affect a person's relationships and quality of life. This disorder often starts during the late childhood or adolescence, and it is quite rare for the first instance of these behaviors to occur after the age of 40. IED appears to follow a chronic persistence course of a period of time. For the prognosis, environmental factors such as having a history of physical and emotional trauma during the first 20 years of life are at risk, also determining if there has been a long-term separation from family members or one's home. Genetic and physiological factors can also contribute to intermittent explosive disorder. The onset of IED usually develops in late childhood or adolescence. This diagnosis can be made alongside attention deficit hyperactivity disorder, conduct disorder, oppositional defiant disorder, or even autism. For cultural considerations, healthcare professionals must be aware of these cultural factors when evaluating, diagnosing, and treating patients with IED. Culturally sensitive methods guarantee that interventions respect the differences in cultural backgrounds and are better able to meet the specific requirements of people who are experiencing IED in different cultural situations. IED can be displayed throughout individuals differently, and it is crucial to consider all factors in an individual. There is some association with suicidal thoughts or behaviors, and there was a study explained by Fanning and others that 1,460 volunteers found that individuals who are diagnosed with IED alongside PTSD have a rate of 41% lifetime suicide attempt. The etiology of this disorder includes that the DSM has included the disorder of impulsive aggression since the first edition of the DSM in 1952. However, the name of intermittent explosive disorder did not exist in the manual until the third edition was published in 1980. Originally, this disorder was classified as passive-aggressive personality aggressive type in the DSM-1. IED is estimated to be between 5.4% and 6.9% within the general population, and it is more common to be displayed in men rather than women. Current theories suggest that there is yet to exist a comprehensive review of genetic and environmental influences on impulsivity. The instruments that are used to assess the disorder are questionnaires and interviews, and the Intermittent Explosive Disorder Interview, IED-M, is a semi-structured clinical interview, and another questionnaire known as the Bus-Perry Aggression Questionnaire contains 30 self-reporting questions based on traits containing anger, hostility, or any level of aggression. For the differential diagnoses, disruptive mood disorder can be considered one of the differential diagnoses. However, being able to differentiate intermittent explosive disorder from disrupted mood dysregulation disorder, DMDD, is the symptoms and the particular age of onset. DMDD is seen before age 10, and IED is seen later on. Also, individuals with IED who display levels of irritability and anger is shown for a smaller period of time compared to those who are diagnosed with DMDD. Antisocial personality disorder or borderline personality disorder differs from intermittent explosive disorder because those who are diagnosed with antisocial personality disorder or borderline personality disorder display reoccurring impulsive outbursts, but not at the same level of impulsive aggression to those who have IED. For those who are experiencing delirium and major neurocognitive disorder, it is crucial to not diagnose an individual with IED. Attention deficit hyperactivity disorder, you can see that individuals may display impulsive, aggressive outbursts, which is typical for individuals with ADHD. However, IED differentiates based on the level of aggression. Substance intoxication or substance withdrawal includes being involved with substances may increase aggressive behavior. However, those who are involved with substance intoxication or substance withdrawal and only have outbursts when intoxicated or having withdrawal should not be diagnosed with IED. The treatment for this disorder includes cognitive behavioral treatment, family treatment, changes in one lifestyle, avoid substance use, and increased relaxation methods. Self-inoculation training, multi-component treatments, inclusion of both cognitive and behavioral practices, medications, including mood stabilizers, antidepressants, particularly selective serotonin reuptake inhibitors. A brief example of a case that I created includes a 35-year-old businessman named Mark who is deeply involved in preparing a presentation while seated at his desk in a busy workplace. Mark's focus is broken as his phone rings. He has been anticipating a very important work call, only to find out the caller is a telemarketer. He feels a rush of frustration come over him instantly. He originally makes an effort to deny the offer, but something is triggered in him by the salesperson as they are persistent. Mark's voice becomes extremely stern, and he becomes angry and starts to yell into the phone, saying harsh remarks and verbally abusing the telemarketer by calling them unpleasant names and making threats. His coworkers nearby exchange nervous looks as his outburst gets progressively worse. Mark keeps on ranting despite his coworkers' attempts to calm him down, and eventually he calms down and hangs up feeling distressed and panting heavily. Mark feels a mixture of shame and regret for his outburst in the office. However, for Mark, this is not the first time that an outburst has occurred. He has seen similar experiences throughout his life, where somewhat smaller incidents turn into violent outbursts. Following these outbursts of extreme rage that are out of proportion to the situations that set Mark off, he feels ashamed. In reviewing this example, we are able to see how Mark exhibits the symptoms of intermittent explosive disorder, IED, a disorder that is marked by frequent, impulsive, violent outbursts, as we have learned previously, and his outbursts are often triggered by small, insignificant events following some levels of embarrassment. Some may think that Mark should be diagnosed with borderline personality disorder, given his aggressive and violent acts and strong mood swings. However, his main pattern of explosive outbursts allow us to diagnose Mark with IED. To differentiate IED from other disorders that may exhibit similar symptoms, understanding differential diagnoses is essential for people like Mark to receive the proper diagnoses and treatment that will help him further manage his outbursts.